So approach to abnormal liver function test. Okay, so let's go. So I want to make sure, like all we do in the past, to make sure that liver function tests are made as simple as possible. And so that we also know how to pick up the big issues so far as these cases are concerned, okay? So we're going to go through approach to abnormal liver function tests. And you know what I hear a lot of candidates say is, Dr. Boni, look, I'm lost with all these LFTs, you know, the AST, the GGT, the ALT, the bilirubin. I'm lost. When I have to deal with it, I'm really lost. And so I'll be very glad that, you know, we're able to go through it. And that is exactly what we will do. And, you know, some candidates have also said that, you know, I really want to make sure that I see the patterns. Because, you know, in the exam, as I've said previously, it's all about pattern recognition. Pattern recognition. I think the last time we looked at patterns so far as members are concerned. This time we are going to look at patterns so far as LFTs are concerned and which patterns are most important for you to master for your exam. Okay, so I'm going to take us through the objectives, but I need somebody to volunteer and read this opening statement for us. Or so I need somebody to even read all the objectives for us. Will I get a volunteer, please?
I don't mind reading.
Okay, sure. Dr. Notabo, please read for us.
Okay. What are the objectives actually saying? Yeah. Abnormal liver function tests are common in clinical practice. Mm-hmm. Appropriate investigation can distinguish benign reversible liver disease from potentially life-threatening conditions. Okay, so first and foremost, when you are studying this objective, you have to ask yourself, what benign liver diseases should I know? Number two, what life-threatening conditions should I know? So Dr. Notabo, since you read it, do you mind maybe telling me about some benign liver diseases every candidate must know and some potentially life-threatening conditions every candidate must know? Benign reversible disease.
Yes. And anyone can also type it in as well. And it's not like I'm putting you on the spot, I'm just asking. Can we say that, you know, fatty liver disease, you know, fatty liver disease is not, unless it's become so bad that it's complex, then we can say that that is a benign one, right? Okay, good. So
what about adenoma?
Sure, hepatic adenomas, hepatic cysts, you know, those kinds of things. Okay, beautiful. Okay, what about life-threatening ones? Can somebody, Dr. Natab, any life-threatening liver diseases?
Liver cirrhosis, liver failure.
Okay, liver failure, liver cirrhosis. What about hepatoma? Right? Good. Okay. So hepatocellular carcinoma. Beautiful. Okay. So now the conditions you must master. The MCC wants you to master acute conditions like the infection. So you need to master hepatitis A to E. Number two, medications. So if I were you, you know, I want to learn some common medications which cause liver disease. And I'll be bringing you some questions on that. And then you also want to look at cholestasis like intrahepatic and extrahepatic, like gallstones causing abnormal liver disease and even cholestasis in pregnancy. Then congenital abnormalities like Gilbert's disease. Now, I'm not going to go into Gilbert's disease now, but I just want to ask a question. Who can tell me something brief about Gilbert's disease in like 2 sentences? Gilbert's disease in like 2 sentences. Anyone? Can somebody help us with that? Gilbert's disease in 2 sentences. What is unique about Gilbert's disease? Okay, number one, remember that Gilbert's disease causes reversible jaundice, right? And most of the time, to pick up Gilbert's disease, you realize that the question will tell you that the patient is otherwise healthy and normal, and the patient has gone through a period of stress. And that stress can be, you know, surgery, sports, the person got sick of any other condition and then developed the jaundice. And you may hear the word recurrent, you know, it happens over and over and over again. And then other conditions which you must master will be celiac disease and abnormal liver function test. If you're able to master these, I think you are good. So the key objective here is that given a patient with abnormal liver disease, liver function test, the candidate will diagnose the cause, the severity, the complications, and will initiate an appropriate management plan. In particular, assessing for any potential underlying liver disease, okay, or liver disorder or systemic disease. So, and then the other key objectives, and I don't want to waste your time with that, but one of the things I want you to do is laboratory tests which are appropriate for the identification of specific acute and chronic liver diseases. So something like viral serology, you must know if you are presented with lab investigations, you must know which one stands for acute hepatitis B, chronic hepatitis B, hepatitis C, hepatitis D, hepatitis A serology, how each of them look like, okay? So this can take some time. We're not going to go into all those things, but I'm giving you those pointers so that you will know what to do. And you must also know how to construct an effective initial management plan, including determining if the patient requires urgent referral or hospitalization, and referring the patient for specialized care, non-urgent, and if necessary, and counseling and educating the patient to prevent further hepatic insult. So I've set some MCQs, and we're going to, we're going to use the MCQs to decipher all these things, okay? So let's get into it right away. So like any other objective, you can use a stepwise approach. And I want to say it again, you can use a stepwise approach to evaluate liver function tests as well. So let's get into it. Now, the liver enzymes you must know are ALT, AST, ALP, and GGT. And then there are tests which look at the synthetic function of the liver, like albumin levels, like prothrombin time, like iron. And then you must also master serum bilirubin level. So you must know which conditions will cause ALT to be elevated, which conditions will cause ALT to be markedly elevated, which conditions will lead to maybe ALT in relation to AST ratio to be abnormal. These are the things you must be looking out for because that's what you'll be quizzed on. That's what the objective is telling you. Okay, so I want somebody to tell me, how do you use AST to ALT ratio to distinguish between alcoholic liver disease and fatty liver disease? Can somebody help us? How do you use ALT and AST ratio to guide you so far? How do you know that this question is talking about alcoholic liver disease? How do you know that this question is talking about fatty liver disease? Because I have some questions we'll be going through, but I want to know, does somebody know? Can somebody help us?
Alcoholic liver disease, AST will be higher than ALT.
In what ratio?
I think 2:1.
Beautiful. Okay. What about fatty liver disease?
ALT is high.
Well, we'll see. What does UpToDate say? So please, who spoke? Is it Dr. Yasmin?
Yes, doctor.
Okay, beautiful. Okay. My ever-present Dr. Yasmin. Okay, so Dr. Yasmin is saying that in alcoholic liver disease, I'm just using this, I just coined it myself, AST over ALT. This is something you must know. You may not be told blatantly, but you can look at the liver function test and use that to tell. And she's saying that it must be more than 2:1. Okay, Doc, what about the hepatic, like the hepatic fatty liver disease? Any idea? Who knows? What's the relation between AST and ALT? So that if you are presented with a case, you can be able to tell that with the AST level and the ALT level, this is alcoholic liver disease, this is fatty liver disease, because this is what you must know. Can anyone help us? So it looks like everyone has dialed in the alcoholic liver disease one. Okay, I will not hold you for that. I will go in and show you how you're going to distinguish that. So Dr. Yasmin, yes, it is true. Alcoholic liver disease will be 2:1, but then we'll come back and then look at something. So if a patient has abnormal liver disease, abnormal liver function, there's a stepwise way you want to assess them. Because you remember that in the CDM at times, they will say, what historical features will you want to know? Okay, so when you're talking about historical features, beautiful. Dr. Tasman said AST to ALT should be less than 1 in fatty liver disease. Beautiful. We'll come to that. So in your exam approach, you need to know, for example, 40-year-old patient comes into the liver clinic and you are assessing the patient. You want to know the risk factors for developing abnormal liver function. What questions will you want to know? The first question you should ask yourself is this patient taking any medications which can cause abnormal liver function? So now I have a question for you. Which medications can lead to abnormal liver function? That's something you need to think about. Number 2, which herbal preparations can lead to abnormal liver function? Which recreational drugs can lead to abnormal liver function, right? These are the steps you need to go through. Number 2, we just talked about alcoholic liver disease. So screen for alcohol use, and you can use the CAGE questionnaire. You know, have you thought about cutting down? Do you feel annoyed? You know, do you feel guilty? Is alcohol the first thing you want to use when you are talking about the CAGE questionnaire, the CAGE? But then the main thing which should pop out to you is, if I were you, if they give me a liver function test, I'll go look for the AST level. I'll also go and look for the ALT level, and I'll compare the two. Don't forget that you already have a calculator in the exam on the board, and I'll compare the AST level to the ALT level. If they're asking me for the diagnosis, and I have AST level to ALT level more than 2:1, say AST is about 2,000, ALT is about 800, then I'm thinking about alcoholic liver disease. You also want to ask questions in relation to risk factors to conditions like hepatitis B, hepatitis C. So you want to ask, you know, MSM, men who sleep with men, sexual practices, IV drug use, blood transfusion, recent tattoo use. You want to ask about all those things. And then you also want to screen for hemochromatosis. And then come back to the AST-ALT ratio. Dr. Tasman just answered that. So we said, how do we use AST and ALT to differentiate between alcoholic liver disease and fatty liver disease? With alcoholic liver disease, AST to ALT ratio is more than 2:1. For fatty liver disease, AST to ALT ratio is less than 1. So for fatty liver disease, you'll get a picture like AST is 100, ALT is 200. So 100 over 200 will give me 0.5. So if I have a patient and I want to know, the options are viral hepatitis, number 2, alcoholic hepatitis, number 3, fatty liver disease, number 4, say hemochromatosis. And they tell me that with hemochromatosis, the iron levels are, like, they will tell me that maybe iron levels are fine. And I also see that ALT level is higher than AST level. Then I'm going to think more of fatty liver disease and less of alcoholic liver disease. So we've gone through the initial way you're going to think about it, medications. And I really wish somebody can type at least 5 medications which can cause abnormal liver function in the comment section. I'll be very glad if someone can type that. I know the commonest one all of us will talk about acetaminophen, but apart from acetaminophen, which other medications can cause abnormal liver disease? So medications, alcohol use, viral hepatitis, that's hepatitis A, B, C, D, E, hemochromatosis, fatty liver disease. So even with this step alone, we've brought out some differentials, okay? Now, I come back to the reason why I'm hitting on this is it's very important. It's very important. It's very important. When Dr. Boni is hitting on something, know that it's very, very important. AST over ALT of more than 2.1, alcoholic liver disease. AST over ALT less than 1, think about fatty liver disease. We move forward. Okay, good. So now, the second thing, you want to also consider autoimmune hepatitis, particularly in women, in those with a history of other autoimmune disorders. So I have a question. While we are typing the answers, I've seen a lot of people typing in isotretinoin, sodium valproate, valproic acid, which ibuprofen, that's NSAIDs, beautiful. A lot of people don't talk about NSAIDs. Methotrexate, beautiful. Now I have a question. Which autoimmune diseases are associated with abnormal liver function? Maybe you can type them in the comment section. Which autoimmune diseases are associated with abnormal liver function? Then the other thing you also want to do will be TSH, because hypothyroidism can also lead to abnormal liver function. And then consider celiac disease, especially when you are looking at serum IgA and transglutaminase antibodies. Okay, so I think people are already typing fulminant autoimmune hepatitis, Wilson's disease. Beautiful. Wilson's disease is wonderful. Tasnin is talking about fulminant autoimmune disease. In fact, what about even type 1 diabetes? Type 1 diabetes as well. Okay, so let me continue and then maybe you will get it. Wilson's disease must also be considered. And Wilson's disease, look for Wilson's disease in a patient who is less than 40 years old. And the key to the Wilson's disease would be checking for ceruloplasmin and evaluating the patient for any case aplasia rings. And you also want to assess for alpha-1 antitrypsin deficiency, especially in patients with a history of emphysema. So you get a case of 38-year-old male with ongoing history of shortness of breath, progressively getting worse over the past couple of months. Okay, X-ray shows hyperinflated lungs, honeycomb appearance, with abnormal liver function tests. And even the question says, look, no history of smoking. What investigation will you want to request to confirm your diagnosis? Your answer should be alpha-1 antitrypsin level. Let me take it again, because don't forget that those who have alpha-1 antitrypsin deficiency, which leads to COPD, they usually get it at a very young age. So most of the time, we know that if people smoke, it takes time for them to develop COPD. But if you're getting somebody around 30-something years old, having signs of COPD, and also having abnormal liver function, the next best step or the next best investigation should be alpha-1 antitrypsin. So those are the equations I want you to look at in relation to AST-ALT ratio, 2:1 or less than 1, medications which cause abnormal liver function, ceruloplasmin levels, tying Wilson's disease into liver function abnormalities, alpha-1 antitrypsin tying COPD to abnormal liver function, and even adrenal insufficiency as well. Okay, so please, then observe if the ALT or AST level is less than 2-fold elevated. Otherwise, you want to consider liver biopsy. So if you look at the upper limit of AST, you look at the upper limit of ALT, and they are not more than 2 times elevated, you may want to hold on with liver biopsy. So even if you see liver biopsy as an option to choose from, you want to withhold yourself. Unless the AST level or the ALT level is more than 2-fold the upper limit, then you may want to consider biopsy of the liver. Okay, so quick review. Let's break some equations on LFTs, and then we will see how well we are doing. I want somebody to take this question for us. Please. Quickly. Somebody to take this question for us. Oh my goodness. Dr. Tawhid, can you read the question?
Okay. Most common drugs which causes acute liver injury in North America.
Beautiful. And you said what? Acetaminophen.
Acetaminophen. Yeah.
Okay. Dr. Tawhid, are you able to hold on? So acetaminophen is correct. The most common drug which causes abnormal liver function in North America is acetaminophen. I have this other question. And then other medications you must know after acetaminophen, amoxiclav, amoxicillin clavulinic acid, trimethoprim sulfamethoxazole as well. Okay. Ciprofloxacin, isoniazid. And then remember that I told you about NSAIDs, non-steroidal anti-inflammatory drugs.
Yes.
And then herbal and dietary supplements like green tea and statins, amiodarone. So look, I want you to be able to identify these, but pick about 4 of them and memorize them: acetaminophen, amoxicillin, statins, amiodarone, NSAIDs. And don't forget, common things are common, so that if you're asked in the exam, you can be able to bring it up. Valproate, phenytoin, methotrexate. These are drugs which cause abnormal liver function. Okay, so we are using this question to deal with that particular one. Now, Dr. Tawhid again, can you please read this question for us and then tell us your answer?
Okay, you are in hepatology clinic reviewing various patients. What is your diagnosis?
So you have a patient whose AST is ALT of 220 and AST of 660. And I've given you the normal ranges for the various laboratory investigations. What is your diagnosis?
So here diagnosis is the alcoholic hepatitis.
Beautiful. Why?
Because the AST is higher than the ALT.
Beautiful. So please, guys, are you seeing the way we are going through it? I'm just bringing up all these things. Dr. Tasman is surprised that green tea can cause abnormal liver function. Yes, it can cause abnormal liver function. Okay, good. So the answer is alcoholic liver disease. And the reason is because remember that alcoholic liver disease gives you an AST to ALT ratio of more than 2:1.
Yes.
Okay? More than 2:1. So that's why we said that the AST was 600, the ALT was 220. That is almost a ratio of 3:1. So that passes the 2:1 ratio. Okay, good. Dr. Tawhid, this other question.
Okay, you are in hepatology clinic reviewing various patients. What is your diagnosis? Here, ALT is 82 and AST 30.
Beautiful. What's your diagnosis?
Diagnosis is the acute fatty liver.
Sure, fatty liver disease. Why?
Because here is also the difference between AST and ALT. ALT is higher than the AST.
Beautiful. Please, is everybody following what we are doing? Please, if you are following, type yes, yes, yes. I don't want to rush through this. I want us to be able to get into the exam and be able to kill the exam, because look, this is very critical. Beautiful. There's no need to go into this exam.
Yeah.
Or there are principles. There are principles, and those are the principles I'm breaking down. And that's why I don't write all those long questions. Because in the long run, when you break down the questions, it should be coming to these key things. If you are dealing with an abnormal liver enzyme, these are the things you need to work on. Okay, good. So it is fatty liver disease. Dr. Tawhid is getting everything right. Why? Because she has a strong foundation. We've already built the foundation, and we are using the foundation to solve questions. If AST to ALT ratio is less than 1, then go for fatty liver disease. Yeah. All right? Good. Dr. Tawhid, let's go again.
You are in hepatology clinic reviewing various patients. What is your diagnosis? A 23-year-old female with a recent episodes of joint pain, early morning stiffness in the hand, and some weight loss over the last couple of months. Her LFTs reveal AST of 1300 international unit per liter and ALT of 1000 international unit per liter. Most likely diagnosis. So, and number 2 is the other labs to request. And number 3, how to confirm your definitive diagnosis.
Beautiful. So what's your most likely diagnosis?
So here is the most likely.
That is correct. Dr. Aruj got it right. Dr. Tawhid, what's your answer? I want to know whether you'll also get the same answer as Dr. Aruj.
Yeah, she is having joint pain, early morning stiffness. Here's again her LFST is 1300.
Okay.
And ALT is 1000.
Okay.
He's again is the alcoholic hepatitis because the AST is higher than the ALT.
No, don't forget that alcoholic hepatitis AST must be more than 2:1. So if ALT is 1000, then AST should be about 2000 and above.
Okay.
Don't forget that here AST here is 1300. And don't forget that look, the AST is really high. It's more than 1000. And that is another thing I will be teaching you that what conditions cause AST and ALT levels to be more than 1000. There are also some differentials there.
Yes. There's viral hepatitis, medications, autoimmune hepatitis.
Well, but what is your topmost diagnosis? You said viral hepatitis. What else? Medication-induced.
Medications, yeah. And autoimmune hepatitis. This is the autoimmune hepatitis.
Why? Beautiful. That is correct. But why? 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 What condition is linking the two? What condition causes joint pain?
Because the patient is having the symptoms which shows she's already having some autoimmune disease like rheumatoid arthritis.
Beautiful. So this is a case of rheumatoid arthritis leading to autoimmune hepatitis. So please, guys, listen to me. This is very critical. The way the question was presented, if you're not careful, you'll miss it. But this is somebody who has joint pains, early morning stiffness in the hands, weight loss, and now the patient also has abnormal liver enzymes.
Yes.
What condition is going to link the two of them? It is an autoimmune process. Now, we've learned that various autoimmune conditions, systemic lupus erythematosus, rheumatoid arthritis, type 1 diabetes, Sjogren's syndrome, but which of these will cause early morning stiffness in the hands, some weight loss, and joint pains? It's rheumatoid arthritis.
Rheumatoid arthritis.
So this is, okay, so now, what other labs will you request for this patient?
So we will do the liver enzymes and liver function test.
Oh, come on. We have the liver enzymes already, doctor.
Okay, yeah.
We have the liver enzymes already. So what other tests will you do? Okay, by the way, how will you confirm your definitive diagnosis? In autoimmune hepatitis, how do we confirm it?
So we will do the antibodies. There is a smooth, forget the antibody.
Don't go into those ones because those ones can also be non-specific. What is the definitive way? Definitive. When you do it, you know you got it right. Kathleen got it right. Biopsy, liver
biopsy. Okay.
Good. So you see, okay. So it is autoimmune hepatitis. Other investigations you want to request will be ANA, SMA, IgG levels, and how you're going to confirm the diagnosis is liver biopsy. Now, where am I even getting this information from? Up to date will tell you, we prefer to obtain a liver biopsy in all patients in whom autoimmune hepatitis is suspected, because histologic assessment can confirm the diagnosis and help guide, sorry, I think somebody's calling me, and help guide treatment. So in any patient with liver autoimmune hepatitis, you know, you need to do liver biopsy. That one is, it's a no-go area. You need to do it. So that is one thing you want to know. Liver biopsy in terms of autoimmune hepatitis. How do you confirm autoimmune hepatitis? Do a liver biopsy.
Liver biopsy.
What investigations will you request? ANA, SMA, IgG levels. When you see any autoimmune condition which is tying in with abnormal liver enzymes, think about autoimmune hepatitis. Beautiful, beautiful. Let's make liver function tests simple so that you can break it down in the exam. Okay, good. Now, in relation to autoimmune hepatitis, because with your QE1 objectives, you also need to know treatment. So quick point, steroids with or without azathioprine is what we use to manage autoimmune hepatitis. Keep it very simple. Don't make it complex for yourself. Steroids with or without azathioprine is what we use to manage autoimmune hepatitis. Okay, good. So teaching point. Now, Dr. Tawhid, remember that I told you that you have to know the conditions which cause LFTs to be more than 1,000.
Yeah, this is.
Yes, beautiful. These are the conditions. Viral hepatitis, so hepatitis B, hepatitis C, acute fulminant hepatitis, drugs like acetaminophen poisoning, okay, autoimmune hepatitis, hepatic ischemia, and less often patients who have bile duct stone, you know, these are the things you want to know, because these are the ones which can, so when you see a patient, so one thing you really want to pay attention to is, as soon as you see a patient's lab work given, and the liver function test is more than 1,000, start thinking about, these other diagnoses, these 5, keep it in your mind. Then after that, you ask yourself, is the question giving me anything in there? For example, if there's a question which talks about somebody who has migraine headaches, very bad migraine headaches, and the migraine has subsided, but then the patient came and the patient's LFTs are elevated, what do you think about? I'll think about drugs like Tylenol, like NSAIDs. Why? Because it could be that the patient took some drugs and that is what has affected the liver function. You see, so look, the exam is all about recognizing patterns.
Yes.
That is something people don't get. And that is something I want you to get. So another thing which should point you to hepatocellular disease is most of the time, if the condition is related to the liver itself, there will be increased AST, increased ALT. If it has to do with the gallbladder, cholestatic causes, then you're looking at ALP and GGT. ALT is more specific. ALT is more specific to the liver, okay? And the most common, listen, common things are common. Don't miss this. The most common cause of elevated ALT is fatty liver. Okay, so you are in the hepatology clinic reviewing various patients, 54-year-old female with ALP of 600, ALT is 50, AST is 30, and GGT is 40. Which other investigations will you consider? Can somebody help us? Maybe let me help you to break this one down. ALT, is it normal or abnormal? ALP, sorry. Is ALP normal or abnormal?
This is high, 600.
High. Okay. What about ALT? Is it normal or abnormal?
It is within the normal range. ALT not too high.
Okay, sure. What about AST? Is it normal or abnormal?
It is also normal, within normal.
What about
range.
GGT? Is it normal or abnormal?
Not within normal. Mildly high. It is not very high.
No, GGT is normal because GGT is 5 to 55, right? And GGT is 40. Okay, so that means AST, ALT, and GGT are all normal. But the ALP is high. Now, most of the time, you won't get a patient whose ALP is just high and the rest are normal. So that means that this is not likely a liver disease.
Yeah.
This is not likely a cholestatic disease because cholestasis, you must also get an abnormality in GGT levels, right? So, what other place do you get ALP being produced from? Apart from the liver. What other place do you...
Gallbladder?
No.
Gallbladder?
No. If it was gallbladder disease, then you should see GGT also going up. But GGT is normal.
Normal. Okay, sir.
Okay. Linda said placenta and bone. But Linda, a 54-year-old woman cannot be pregnant. So you see, this question is very critical. So ALP is bone. And ALP is the only one increase. GGT is normal. Therefore, this patient does not have actual liver disease, even though the liver function is abnormal liver function ALP. This patient has a bone disease.
Paget's disease of the bone?
Yes, the patient has a bone disease of a sort, and you have to do various x-rays, bone mineral density, bone scan, CT scan to evaluate various bones, okay? So the teaching point is this: if ALP is elevated alone, rule out bone disease. So you see the various ways, because the question said 54-year-old, somebody's talking about placenta. It can't be placenta. Why? 54-year-old men don't get pregnant. ALT is normal, AST is normal, GGT is normal. So that means it is not a liver disease, it's not a gallbladder disease. Are you following me? Therefore, it can only be a bone disease. Beautiful. So look at the way we are breaking things down. Okay, so 50-year-old female presents with elevated liver enzymes. She has a history of systemic lupus erythematosus. Which of the following is the most likely cause of the elevated liver enzymes? Let's go. In the next 10 seconds. Autoimmune hepatitis. Beautiful. That is the answer. The answer is autoimmune hepatitis because the patient has SLE. Okay? Okay. So autoimmune hepatitis. Next question. 45-year-old female, 45-year-old obese male with a history of type 2 diabetes presents with elevated liver enzymes. AST is 80, okay? ALT is 110. He denies any significant alcohol consumption. On physical exam, there is no hepatomegaly or signs of chronic liver disease. Which of the following investigations should you order next? What should be your answer?
Anti-neutral antibody and anti-smooth muscles antibody. Because it is
a different answer. Linda is going for B. So why are you going for C? Liver biopsy right away? You've not even done anything for the patient. You have to do an abdominal ultrasound. And this is because in this scenario, the patient is presented with elevated liver enzymes and no significant alcohol consumption. So it is not alcoholic liver disease. The next appropriate step is to order an abdominal ultrasound. An abdominal ultrasound can help assess the presence of liver steatosis and rule out other structural abnormalities like a liver mass. It is when you see a liver mass, then you want to go on to do a liver biopsy, right? So you don't just jump to do a liver biopsy. You do a non-invasive investigation first. Because if you are biopsying, what exactly are you biopsying? It's just a little, elevation. And remember that we also said that if AST and ALT levels are not way elevated, then hold on with biopsy. So first you want to do an ultrasound, then you then go on to do the biopsy if there's any concern there. Next question, 60-year-old female presents with elevated liver enzymes. She has a history of chronic hepatitis C. AST is 50, ALT is 60. Viral load is undetectable on current antiviral therapy. Which of the following is the most appropriate next step? Which of the following is the most appropriate next step? Anyone with the answer? Hepatitis C, AST of 50, so marginally elevated. ALT of 60, marginally elevated. Viral load is undetectable. Which of the following is the most appropriate next step? Dr. Ruj is saying switch to a different antiviral medication. I bet to differ.
We will continue the current antiviral therapy because this is
beautiful. I think that is the correct thing.
Yeah, because the viral load is detectable, so we will continue the same thing.
Yeah, so that means that the medication is working. So the patient has chronic hepatitis C infection and is currently on antiviral therapy with an undetected viral load. Okay. In this scenario, the appropriate management is to continue the current antiviral therapy. Why? Because the viral load is normal. Sustained viral response is associated with improved liver outcomes. And if the patient has achieved an undetectable viral load, continuing the current therapy is the recommended approach. That's all. So there's no need to switch the medications. Just stay on it. Okay? So trying to wrap things up, you've got to know how to manage, because the objective also states that you have to manage complications of chronic liver disease. And some complications can be esophageal varices, ascites, and with ascites, you must know how to manage the ascites itself and a complication of the ascites like spontaneous bacterial peritonitis. You must know how to manage things like hepatic encephalopathy. Okay? So I'm going to wrap up with that. You must know the precipitating factors for hepatic encephalopathy, like hemorrhage, excessive dietary protein, paracentesis, alkalosis, trauma, okay? Infection, colon, surgery, and sedatives. You must just know them. And then you must know, I don't want to read through everything, but you must know that if somebody has encephalopathy, you are going to give lactulose. You're going to give that, all right? So please take your time and evaluate hepatic encephalopathy, spontaneous bacterial peritonitis as well. Now, spontaneous bacterial peritonitis, if the patient develops it, you're going to manage it with IV antibiotics, so like ceftriaxone or cefotaxime. And you can also give an albumin infusion. And if the patient has cirrhosis with GI bleed, then you want to give IV ceftriaxone daily. But if the patient has a previous episode of spontaneous bacterial peritonitis, then you want to give prophylaxis daily like norfloxacin, trimethoprim, sulfamethoxazole. So learn how to deal with these things. Okay? Okay. And other topics I wanted to review will be the serologies for hepatitis A to E, hemochromatosis and its effects on liver function, and the best next step for hemochromatosis, Wilson's disease and its effects on liver function, and the next best step for that, and then hepatic ischemia and its effects on liver function test. These are the things I want you to actually master, aside all that we've talked about the ratios, about the conditions which lead to excessive liver enzyme elevation, more than 1,000, like hepatic ischemia, medications like acetaminophen. I want you to learn all these ones as well. Hemochromatosis, Wilson's disease, hepatic ischemia, hepatitis A to E serologies. Okay,